thank you, Chad, for setting up perfectly what I want to talk about today, which is that exact problem of this path with Alzheimer's disease and related dementias is not a couple of year process. I've been at Emory for 16 years, and I saw a patient last month that I've been seeing since the day I walked into clinic. And so some of these patients are with us for a very long time. And as you very astutely pointed out, diagnostics is so important, especially when we can match them to disease-modifying treatment early. But when they get that disappointing answer that no, you're not a candidate, or no, this is Lewy body disease or frontotemporal dementia, and there aren't real disease-modifying treatments available, they still have an entire decade or more of symptoms that are going to come up. And they won't all have the exact same symptoms. They want to know that too, by the way. Who gets asked, am I going to be that guy that, you know, runs out of my house, or that is my mom going to be that aggressive one that fights me when I bathe her? We don't know. But inevitably, most of these patients, large percentage of these patients, are going to have some behavioral psychiatric symptom of their disease, and some other neurologic consequences like Parkinsonism that'll come along in the course of their disease. And for the past couple of decades in cognitive clinic at Emory, myself, our other nurse practitioners, our MDs, we've been managing those symptoms, and we've been holding those patients well with the help of our social workers. And what we're learning is that if we're going to do excellent diagnostic care and use our expertise, and we're going to use our expertise to manage long-term, we're in a pickle because there's not many of us. And you all are getting these questions before they ever get to us. And then if they have to wait a year to get in to see me to address their hallucinations, they're already in a psych facility by then. And so having you all in the room is part of that greater vision of Georgia MemoryNet to educate our primary care providers on some of these basic management strategies. And it's amazing. I joke that my social workers have given me a social work degree. My geriatric psychiatry friends have given me a psychiatry degree over the past 16 years because there are some basic things you can learn. And so I want to spend the majority of my time today talking about some of those common symptoms and how to deal with them both non-pharmacologically and pharmacologically. Because what do we know? Are drugs great for older adults, especially multiple drugs? Absolutely not. And so it's not always a medication management issue. Sometimes it's just a few tips for that caregiver on how to manage their loved one, how to not argue, things like that. So we'll talk about a few of those non-pharmacologic management tips as well, and tips to empower your caregivers. I've shown this slide probably a dozen times in the past year, and it's exactly what Chad was getting at. Can anybody read the tiny number of cognitive neurologists that there are in the US? How many of us are there? There's about 550 out of over 15,000 neurologists. And then if you compare that to the number of primary care providers. And this slide gets at what Chad was talking about, that we can identify preclinical AD in patients much earlier. And then once there are prevention trials that come out that show treatment, that wave of patients that are going to want and need care and going to want and need disease-modifying treatment is just going to continue to get bigger. And so we can't keep trying to hold up the wall with a few tiny specialists. We have to spread that net a little bit. And I do believe that I sat down with several of our primary care providers at Emory this past week, and they all said, we understand that the chronic care management of dementia needs to shift somewhat to primary care. But you can't do that if you don't know how to manage it. And so, again, thank you for being here, and also thank you for showing up for your patients every day. There we go. So if you were at the symposium last year, we talked a good bit about differentiating between the types of dementia. I can't tell you how many times my patients have either come in and said, my general neurologist or my primary care said my MRI was normal, so I don't have Alzheimer's disease. Or they said it's just dementia, it's not Alzheimer's disease. And what I want to point out with this slide is that just dementia isn't really a thing. It's an umbrella term that encompasses so many different diseases. By far, the most common is Alzheimer's disease. Chad, I have no idea how you made that little light thing show up. Oh, well. So Alzheimer's disease is by far the most common, and it's also one of the most feared words that patients and families hear. And so normalizing that, we talked a minute ago about stigma, is really important. And the reason that that actual term is important is because it can match them to therapies that are helpful. Same with Lewy body dementia, vascular dementia. We have Parkinson's disease dementia. Frontotemporal dementia, less common, but can be pretty devastating to families because of the behaviors that come along with it or the speech challenges. And then you have a small percentage of patients with alcoholic dementia. What I do want to point out, though, is that a huge percentage of our patients have coexisting pathology. And so a lot of my patients that I diagnose with Alzheimer's disease on day 1, by year 2 have developed emerging Parkinsonism or hallucinations, and oh, they probably have DLB. I can't really test for that, but I should pay attention to that because they may be more sensitive to medications like your antipsychotics that they might actually need for their hallucinations. And so it's important to understand the overlap with that and also with vascular dementia. Vascular dementia almost always presents as a mixed pathology and most commonly with Alzheimer's disease. So these are the most common symptoms that we see in our clinic and that you probably see: depression and anxiety, irritability and agitation, apathy, hallucinations, delusions and paranoia, disinhibition and impulsivity, sleep disturbance. Who knows what anosognosia is besides my guys in the back? It's a lack of awareness of one's own symptoms. How many of you have sat with a gentleman for 30 minutes who's been flying fighter jets and now is being told he can't drive and he thinks he's still fully capable and doesn't recognize his cognitive symptoms? That was my favorite guy. You can't tell me I can't drive. I've been flying fighter jets longer than you've been alive. And you got, what, 10 minutes for an appointment? And that's the guy in your office? So I recognize I'm asking you guys to manage some pretty challenging things. And then Parkinsonism, quite common. So question for the group. Which of these symptoms that I just put up on the screen do you most commonly see if you had to pick one of these? What do you guys see? None of them? Yeah. Pick a couple. What are the top? What bubbles up to the top? Agitation. We see that a lot. Sleep disturbance, big, big issue. Are they going to tell you they're not sleeping well? Or is their wife going to tell you they're not sleeping well? Yeah. Quite often you're going to hear from the loved one. Do your caregivers talk to you in front of the patient and bring up these concerns? Sometimes. Do they send you a note ahead of time that's 4 pages long? Yeah, we get that too. I will say for patients, for families, especially with those anosognotic patients who don't recognize their symptoms, I will often tell their wife, hey, ahead of time, will you just send me the 5 things you want, or the 2 things you want to talk about today? It can be really helpful for them to summarize ahead of time, and then you can kind of creatively address it in the visit. So agitation, I heard. Sleep disturbance, I heard. Which of these symptoms do you find to be the most difficult to manage? Paranoia, super difficult. Agitation's tough, especially when they're starting to get aggressive and loved ones are trying to figure out how to manage that. Want to keep them safe in the home. Also don't really want to admit them to an inpatient facility because they're likely going to get worse and get put on drugs that are going to make their symptoms worse. So I want to go about addressing these symptoms by walking you through a case. And so this is a story of a gentleman I met probably 8 years ago or so. At the time, he was 72 years old. He was diagnosed with mild cognitive impairment. He's married. He's financially sound. He's got a master's degree. He was a businessman, really beautiful relationship with his wife. They had moved to a senior community, a continuing care retirement community, so he had kind of all he needed right there in front of him as he lived out his disease. His spinal fluid, we did do CSF on him, was borderline for Alzheimer's disease, but his amyloid levels were quite low, and he was pretty amnestic, and so our suspicion that he had Alzheimer's pathology was pretty high. He was started on cholinesterase inhibitors, and he actually was really sensitive to them. Aricept, even at 5 milligrams, gave him horrible diarrhea, so he ended up on the rivastigmine patch, but he had a pretty robust response. When he first started on it, wife said, man, he's more on it, he's more with it, he's a little more engaged. When you see a robust response to cholinesterase inhibitors, anybody know what pathology you think about? Who tends to respond better to these? Lewy body dementia, that's correct. So they have more of a cholinergic deficit. So starting to already wonder about this guy and whether there's other symptoms or other pathology going on with him. Wife provided a summary of her concerns via MyChart ahead of his visit. because when discussing his cognitive symptoms, he tended to, as she put it, deny them and insisted that he was just like his other aging friends. And then she reported feeling like she had to tiptoe around certain subjects like finances or driving because he'd lose his temper. And he's generally more apt to get impatient at social events. It's time to go, honey, time to go. And he'd get really irritable and argumentative if she didn't leave when he was ready to go. So what symptoms do you see in this guy already? Which are these symptoms? Some agitation, irritability. What else? He's got a little bit of anosognosia as well. Not terrible, but it's definitely there. What would you recommend for this guy based on what you just heard about him? Any treatment needed at this point? Any medications? You might add memantine. Okay. He's at mild cognitive impairment stages, so may want to think about whether he needs that yet or not, but I have seen it be helpful with agitation and irritability. If his irritability is pretty minor and he's getting ticked off when you've been sitting at the party for 2 hours and he's out of his element, maybe you coach the wife a little on, hey, maybe you limit the amount of time you're out. Sometimes there's just little tricks you can give, and they may not need medication. What about the anosognosia? Anything you want to do about that? Let's talk about that. I'm going to warn you, I don't have a pharmacologic slide for this one because there are no treatments for this symptom. Okay, there's no medication treatments. And I know my slides are busy. I want y'all to have access to these because I think these tips are helpful. We won't go over every line item on here. However, it's a lack of acknowledgement of one's own symptoms. It can occur in up to 70 to 80% of patients with dementia. Super common, and it's a broad spectrum. We got some patients that have zero awareness, some that have full awareness, and everywhere in between. And often it results in insistence on maintaining independence. My most challenging patients are those who have anosognosia, and they were the head of the household and managed every single thing and were fully independent and managed large companies as well. They're really fun to work with. And they're really challenging for their family members. And so we spend a lot of time talking to family members about distraction and diversion, avoiding confrontation. Number one rule for my caregivers, anybody know what our number one rule we teach our caregivers is? Don't argue unless it's a matter of life or death. Okay? So teaching families to kind of behind the scenes put in safety nets for things like finances so that it doesn't have to be a daily argument is really helpful with this symptom. Not bringing it up all the time and not using logic and reason, it doesn't work. And what I always tell people is your loved ones' reality is their reality. And if they don't remember or don't believe something is true and you have an alternate reality, trying to mesh those two and trying to bring him onto your track is really challenging. And so I never want my caregivers to try to convince their loved one. And a lot of times they'll come to me and say, tell him he's got Alzheimer's so he'll stop arguing with me. And I go, they're not going to stop arguing with you. So it's very much a caregiver perception that needs to change. And there is a difference between denial and anosognosia. As a matter of fact, most of my patients are not in denial. They truly can't recognize their symptoms, and that's where caregivers get stuck because they feel like they need to convince their loved one. In terms of irritability and agitation, we all know what this looks like, and it can go anywhere from just being reactive and irritable, and that guy that was always pleasant to live with is now just on edge all the time, to actual verbal threats, to physical altercations, and often it's triggered by overwhelm. And so talking to families about how to decrease that overwhelmed environment can be really helpful to these patients as well. Irritability usually indicates that the person's either confused or that they're overwhelmed. And another important thing to tweak out is whether or not this is also a symptom of underlying depression. If they're irritable and frustrated every time they can't do a task that they could always do well when they're trying to put the taxes together and they're just losing their minds, that's probably just some irritability triggered by their cognitive symptoms. If they're constantly irritable and they're withdrawn and they're not sleeping well and they seem a little down or they're starting to make comments like, I don't want to live like this anymore, you might want to worry about some depression as well and consider treating that. However, you always want to make sure there's a safety plan in place when these agitated patients get really ramped up. And so you want to talk to caregivers about that as well. We talked about coexisting symptoms of depression and anxiety and assessing for those. This was brought up earlier, but our cholinesterase inhibitors are often first line for behavioral symptoms. And so if they have Alzheimer's disease or Lewy body dementia, and they're starting to get irritable and reactive, or they're starting to have some mild paranoia or delusions or hallucinations, making sure they've at least been tried, if they're a candidate, and there's no contraindications, on donepezil, galantamine, rivastigmine, one of these cholinesterase inhibitors, may actually help with some of those symptoms before going straight to the SSRIs, or even with more severe psychotic symptoms, the antipsychotics. And so keep that in mind. Those medications can be therapeutically helpful for some of these symptoms as well. And in moderate to late stage disease, which I think somebody already mentioned this, memantine can actually provide some mood help with agitation and irritability particularly. The one thing I'll mention about that is it can also increase confusion, increase depression, increase irritability. And so I always tell my patients that. If this makes them worse, stop it and call me, because in a small percentage of patients it will make things worse. And then SSRIs can often be very helpful. We commonly use escitalopram, sertraline. I really have come to like sertraline, especially for my irritable patients, and especially those that are a little obsessive. It seems to work well in my older adults. And then if they're also not sleeping, you could consider trazodone or mirtazapine. Again, you want to watch these patients closely, watch for sedative effects of some of those drugs. Really want to avoid polypharmacy with these patients, make sure they're not on anything that could be making their symptoms worse. I already mentioned the memantine piece. And then it is so easy to go to something like a benzodiazepine because they work quickly and it chills them out. But really long term, I use maybe once a year I'll put a patient on a benzodiazepine, if that gives you any perspective on how rarely we use it in clinic. It's not going to provide long-term help for the symptoms. It's just going to end the moment, chill them out. And if it's severe, you may want to start an SSRI and have the benzo or the Seroquel if they're psychotic for short term, just till they get the SSRI in their system. But I don't use them long-term in my patient population very often at all. So now he's back to see me a couple of years later. He's starting to have increased sleeping difficulties, and he's acting out his dreams. He's kicking, punching, moving around. One occasion, he thrashed so much in his sleep that he fell out of bed, and his spouse is not sleeping because he's keeping her awake. He's also spending more time at home. He won't play golf when his friends invite him. He's quieter when he's out at dinner. He doesn't offer to help around the house anymore. So what symptoms are you starting to see in this guy now? Possibly depression. REM, sleep behavior disorder, so he's acting out his dreams, correct. What disease do you most commonly see that in? In Lewy body dementia, correct. Anything else with him? What about apathy? You think he's depressed or you think he's apathetic, or both? Hard to say, right? So any recommendations for this guy? Would you treat his sleep disorder at this point with medications? He's kicking his wife. He's falling out of bed. What if he's on a blood thinner? So let's talk about sleep. Many manifestations of sleep disturbance, and many of them, poor sleep can also lead to worsening cognitive symptoms or can be precursors to developing dementia earlier if you have untreated sleep apnea, long-standing insomnia, trouble sleeping. They can also be hints. And so the REM behavior disorder is one that we commonly see before Lewy body develops, before the dementia symptoms come on. And it's important to assess for. It's also important to assess for because it often leads to caregiver exhaustion. There's a lot of day-night reversal in our later stage patients as well because they're up at night, then they fall asleep in the daytime, and that cycle keeps going. So it is important to talk about consistent sleep schedules. One of my favorite things to recommend for sleep disturbance is some sort of daytime activity like a day program, because a lot of these folks are sitting at home in front of a television, falling asleep, and then not sleeping at night. And then for the REM sleep behavior disorder, setting up a safe sleeping environment is going to be really important. A lot of these folks end up in separate beds. Yes? Depends on the environment and the ability of the caretaker to manage that, right? So if they're in a memory care unit and there's an ability to kind of deal with their sleep funkiness, for lack of a better term, it might be okay. And but a lot of times caregivers don't have the capacity to be up all night and then up all day managing daily life. And so trying to get them into a routine, trying to keep them active is important. But also late stage, that looks very different than in early stages. Great question. So for sleep disturbance, one of the things that we often forget to do is screen for sleep concerns. And your caregiver or bed partner is a crucial part of that history. In milder patients, keeping a sleep diary can be helpful. Some patients you do want to order, and now that we have home sleep test, I will sometimes do this, especially if I'm worried about sleep apnea in these patients. Do a sleep test and just confirm that there's nothing major going on that needs treatment. But melatonin has actually been proven to be very helpful, both in REM behavior disorder, but also in other sleep disorders. And you can titrate up to 10. I've got some patients on 12 milligrams, especially for REM behavior disorder. So I will often try that first. And you just have to be careful about different formulations because it's not exactly FDA regulated. Trazodone or mirtazapine can be helpful if you really need a medication. But as I said earlier, sleep is often more of can be helped by adjusting the environment and doing some sleep hygiene related tips as well. Our older adults also have bladder symptoms. They're up at night with that. So those are things to consider as well. Clonazepam, it's one of the few times I'll use clonazepam, but if they're not responsive to melatonin, low-dose clonazepam can really help, especially with these that have injurious behaviors and are really acting out their dreams and you're worried about them hurting themselves or someone else. Ropenetrol could be a second-line treatment or can be a treatment for periodic limb movement disorder and RLS as well. Please do a medication list review on patients with sleep disturbance. Quite often you'll find, hey, they're taking their Wellbutrin right before they go to bed, or just some things like that that are activating that they're taking right at bedtime. They're taking their diuretic at bedtime and up all night going to the bathroom, or they're on very activating drugs in general that they don't tolerate anymore at age 80 that they were fine on when they were 50. So always do a med review. And then please don't use antihistamines, antipsychotics for sleep. Number one, they're going to make their cognition worse. Number two, they're not indicated for sleep, and they're probably going to make older adults more apt to fall and have other side effects. Same thing with Zolpidem. Had a 90-year-old, had been on it for years, fell and had a subdural and ended up in the hospital for that. Just be careful with it. I am not good at this button. Apologies. Apathy is incredibly common, and I actually see it a lot in vascular dementia, and it can be very frustrating to caregivers because they just knew this person that was so active and engaged, and now dad sits at the table and doesn't really know what to do after breakfast, or all he wants to do is watch Westerns all day, or we go to dinner and the kids are in town and he doesn't say a single word. And so if it's really just that, if they're really not as engaged, it's probably their underlying dementia and not depression, okay? But if there are other symptoms of depression, in older adults most commonly with depression, I see irritability as kind of the prominent depression symptom. And so if they're just apathetic, but they're not irritable and they're sleeping just fine and they're not too anxious, then I don't worry too much about depression. But you do want to screen for some of those coexisting symptoms. And caregiver education on this is that structure and routine is what helps. You cannot nag a person into being unapathetic, okay? And caregivers don't like being nags. And so I always say, call Bob down the street and have him knock on the door and ask your husband if he wants to go for a walk every morning. Set up a day program for this person. Anything they can do to set up some routine and activity can be really helpful. Because I personally have not used a lot of medications for apathy. Some of my geriatric psychiatrists will try methylphenidate. Works in some patients, doesn't in others. Really want to make sure you get a baseline EKG and monitor blood pressure if you were to try methylphenidate. But I have just found in my practice that it's not exactly the most helpful drug for apathy in dementia specifically. But it is, if we are talking about medications, one that could be tried. Don't treat it as depression if it's not. And then research has shown that higher doses can be helpful of the methylphenidate in some patients. But again, in just my own experience, I'm not a huge fan. Yeah, so if there's some potential, and again, there's no 100% way to know if this is truly just depression or truly just apathy or if it's also depression. I like Wellbutrin. For those who don't have concerns with blood pressure, I'll sometimes try Effexor as well, have them take it in the morning. So yes, that can be activating and can sometimes be helpful. Great point. So he's back to see me again, 5 years into diagnosis. Now he's having trouble opening jars. His speech is a little softer. His handwriting's gotten smaller. I did an exam, and he's a little bradykinetic now. He's got a little bilateral hand tremor, a little worse on the right, and some mildly asymmetric rigidity in his upper extremities. He is still going to the gym every day, and he's walking his dog through his retirement community. But, oh, by the way, while he's walking through his retirement community, neighbors have started to tell his wife he'll occasionally make rude comments, either at mealtime or when he passes them on the sidewalk. So what kind of symptoms are you now seeing with this patient, or with this patient? He's got some Parkinsonism and some disinhibition. Absolutely. His disinhibition, thankfully, is fairly mild. But, man, in the retirement community, they start to talk about you. So it's good to coach families on what to do. What would you do for this gentleman in terms of, let's talk about his disinhibition first. Any pharmacologic treatments for that? Maybe. Talk more about that. Sometimes, if they're obsessive, yes, it might like kind of make them a little less apt to kind of obsessively go up and talk to people, maybe. Otherwise, we struggle with medications for disinhibition. What would you tell his wife? What if he's starting to like go up to random folks and want to hug their children and making people really uncomfortable in the store? What if he's starting to steal stuff, try to get away with it? So it's common and very disturbing, and it can go, you can see the whole gamut of how disinhibition can show up. Behavioral variant FTD is really common for these types of symptoms, but we also see it in other dementias. And families will freak out. And so a lot of times this leads to a lot of isolation because they're afraid to take their loved one out in public. There are awareness cards that you can get through the Alzheimer's Association that caregivers can keep in their pocket and just kind of slide it to that nervous mama who, you know, your husband just hugged their kid, that says, hey, my loved one has dementia and may say some things that make you a little uncomfortable. I'm sorry. And then educating caregivers on how to talk to family and friends about this and making a joke out of it. I mean, sometimes it's all right to just be like, ha-ha, Dad, you know, and just try to play along, do some improv, and slowly get that person away. And then avoid situations where you know it's a trigger for that person. A lot of times they do this when they're overwhelmed in a situation, or and it's good to set expectations for things like holidays as well. When there's too much going on, a lot of these patients are going to really struggle, and so you have to think about how to modify how they go out in public or join family events. Some of the mood stabilizers can help. Again, I don't use these a lot unless it's very severe. And so to your point earlier about SSRIs, for frontotemporal dementia specifically, studies on drug management of behaviors in frontotemporal dementia show that possibly SSRIs can be helpful. And then if it gets really more severe, especially if they're acting out, occasionally some of these mood stabilizers can be helpful. Again, I reserve these for really severe symptoms that are creating a major problem for patients and families in their day-to-day life. Be careful with titration on Lamictal and going slowly. You need a lot of baseline labs for Depakote, as we all know. Anybody know what I often see with Depakote if we start a patient on this and get too high on the dose? In my elderly patients, would you put this patient on Depakote? How about that? Why not? His Parkinsonism is going to get way worse, okay? He's going to come in drooling in my chair and shuffling because he's already Parkinsonian. Most likely he will, so be careful with that. So for his Parkinsonism, oops, let me go back. Oh, no, that's the right one. You know what Parkinsonism looks like. A lot of patients want to know when they're developing Parkinsonism and they already have Alzheimer's disease, is this Parkinson's disease? Do you want to send me across the hall to your movement disorders group. Usually not. We're not usually looking at a separate idiopathic Parkinson's disease, especially if they've had dementia for a while. Parkinsonism is quite common. It's usually going to be asymmetric. It's usually going to be pretty mild. And the thing you worry about really with these patients is falls and also just their ability to maintain their activities. This guy was a golfer, really active. His Parkinsonism was getting in the way of his symptoms. And so what I actually did with him is try him on a low dose of carbidopa-levodopa, titrated it up. He surprisingly had a pretty robust response to it and was able to keep playing golf for a few years on, I think we ended up at 2 tablets 3 times a day of carbidopa-levodopa on him. But a lot of my patients who, by the way, which disease process do you think this guy probably also has besides just Alzheimer's disease? I think we've already said it earlier, but he likely has Lewy body dementia, okay? At least some coexisting Lewy body pathology. In Lewy body, the dopaminergic effects are variable. I've had patients that I'll titrate all the way up to 2 to 3 tabs 3 times a day, and it does almost nothing for them. So you only want to use it if it's actually showing some benefit. That also can help you tweak out whether or not it's idiopathic Parkinson's disease or not, because they're going to have a pretty robust response if they're really dopa response, or if they're really dopa responsive, it may be coexisting PD. And then just keep in mind, severe Parkinsonism can occur late stage dementia, and pretty much always does in very, very late stages. And so that's how they get so rigid. And you're not going to treat at that stage with medications. Exercise is so critical with these folks. And so I want these people up and moving. You can consider physical therapy, and there are some Parkinson-specific physical therapy programs out there called LSVT, both for physical therapy and also for speech therapy for those who are having a really hard time with speech production and projection. So that's something you can consider, especially for these mild folks. And we've talked about Sinemet. Do avoid some of the anticholinergic Parkinson's medications. I've never put a patient on any of those that are listed there because of the risk of making their cognitive symptoms worse and increased confusion, increased sedation with those drugs. And then be very careful with carbidopa-levodopa because it can make them hallucinate and have worsening psychotic symptoms. Very slow titration. I usually start at half a tab twice a day, and then every week go up by about a half a tab and reassess at 1 tablet 3 times a day and see how they're doing before I go any further higher. So still seeing this guy. He's now in early moderate dementia. He started to be tearful when he discusses his cognitive deficits. And his wife reports that he's more withdrawn and wants to be home with her all the time. He's gotten very clingy. He'll call her a dozen times if she goes down the way to get to the pharmacy and back. And he wants her right there every night when he's going to bed. She actually called me when she planned and got caregivers in the house and all of that, and finally took a vacation. And he called her hundreds of times a day while she was gone. Just very on edge, needed to know where she was. Would get short of breath, just really upset. And then he started to believe there's snipers outside trying to find them when they go to bed at night. And sometimes he'll see little animals wandering around their room. So, what are we seeing here? So he's probably got some depression. He's definitely got some anxiety. And now he's also having some hallucinations. What are you going to do for this guy? Would you treat him with medications? So he's calling hundreds of times a day if she's not home. So we treated him, and we started with an SSRI on him. It was very effective, calmed him down. Took a while. It didn't happen overnight, but the wife was really great, and I coached her through kind of helping him breathe, distracting him until the medication came into effect, and he did really well with his SSRI. But when those hallucinations started ramping up, it was problematic. It was keeping them both up at night. He was getting really paranoid. He wanted to call the police. So with hallucinations, delusions, and paranoia, yes?
What did you do with the carbidopa-levodopa at that point?
So he, at that time, was still on a fairly low dose, I think. At some point, we tried reducing it, and his Parkinsonism got so severe that we went back up on it. But we did consider that because of the hallucinations. And when I reduced it, the hallucinations didn't get any better. So we kept him on his carbidopa-levodopa after doing a trial on a lower dose to see how he did. But it was so functionally limiting at the lower dose that we put him back on the regular dose. The thing to keep in mind with delusions and hallucinations is that they don't always need a medication. And normalizing hallucinations for some patients can be helpful. One of my patients I told years ago, there's this disease that you have called Lewy body, and it plays tricks on your mind. And so those kids you're seeing playing out in the yard that your wife doesn't see, that's just part of your disease. And he was like, oh, okay, cool. And his wife would just remind him of that. That's Lou playing tricks on you, and it would work. And so if that works, then go with it. And if it doesn't, then you may need to treat, or it really depends on the severity. I'm very careful to put patients on drugs. And again, as we mentioned earlier, and I'll jump to the medication management, cholinesterase inhibitors can often be really helpful, especially in Lewy body patients, to reduce their delusions and hallucinations. I believe we're going to provide copies of these slides, by the way, if people want to have access to them. If you're going to need to use an antipsychotic, and I often go this route if I'm worried that the patient's going to be on the path towards a psych hospitalization and I want to keep them safe at home. The first line antipsychotic that I almost always use is quetiapine. It is the weakest antipsychotic, meaning it's the least effective. But in older patients, that's okay. And that's what I tell my patients. We do talk about the black box warning, and I start very low. Sometimes I'll start on 12.5 milligrams at bedtime. They'll cut that tiny pill in half, especially with my Lewy body folks, because I put one guy on 25 milligrams one time at bedtime, and he slept for like 2 days. So they can be very sensitive to these medications. And if you put a Lewy body patient on Abilify at like the standard starting dose, you're almost certain to conk them out for a few days. So be very careful with the stronger antipsychotics. But when they get really ramped up and the quetiapine's not working, you can titrate. That's the beauty of the dosing range. So I've got one patient, and I still can't believe she's been on 300 milligrams a day for years, and it works. She's had no side effects from it. But it gives you a dosing range is all I'm saying. Whereas some of these drugs like risperidone, you don't have much room to wiggle, and it'll often make them Parkinsonian. But I will switch from the quetiapine if we've titrated up to about 150, 200 milligrams a day, and it's not doing anything. And often I'll try risperidone in place of that. Some of the newer antipsychotics, word is still out on whether or not those are helpful. My geriatric psychiatrist have tried them off and on and had mixed results. And so I have not spent a lot of time with those if I'm getting good effect from these other drugs, especially because of the cost. Depression, anxiety, we've hinted at quite a bit, and my time is up. So SSRIs are typically the way to go. I've already mentioned some of my favorites. And then again, you've already brought up the question about if more activation is needed. I like mirtazapine for my little older ladies who aren't eating and aren't sleeping and they're irritable. It can work really well as well. So be careful with Paxil. It's got anticholinergic properties. And those are all the symptoms that we're covering today. There are some great caregiver resources here. Savvy Caregiver is my favorite thing, and we'll talk about that tomorrow morning. But I can't speak enough to that online program and educating your caregivers, because you just don't have time in clinic every day to talk about all this stuff. So thank you all. Thanks for all that you do. Really appreciate you.